Hello. Welcome everyone to the first ever PressProgress Health Panel. We're joined today by around 50 people and counting, and we're so glad that you could all make it this afternoon. My name is Brishti Basu. I am PressProgress's health reporter and editor of Pulse Check, our in-house health newsletter. Helping me run this shindig behind the scenes is our brilliant publisher, Romy Garrido, and our Ontario reporter slash resident tech whiz, Eric Wickham. Today's discussion is all about when provinces go rogue with their health policies, implementing ideas that defy federal laws or defy scientific evidence. We'll hear from our panelists first and answer any questions from the audience at the end. If you have a question, please use the Q&A feature on Zoom at any time throughout this event, and we'll try to get to you following the discussion. You can also turn on closed captions using Zoom features down below. So without further ado, I'm so pleased to be joined today by our expert panelists. Please turn on your videos, panelists. Thank you all for making the time on this summer afternoon to share your insights with us all. Introducing, in no particular order, Chris Galloway, the Executive Director of Friends of Medicare in Alberta. Chris is an experienced community organizer and advocate for public health care. He's also has experience working for the Alberta Federation of Labour. He's worked in 3 provincial legislative assemblies and for a variety of nonprofit and community organizations. Next up, we have Dr. Ryan Harriott, a family doctor and addiction medicine specialist in Victoria, BC, who also co-founded Doctors for Safer Drug Policy, which is a group of Canadian physicians who advocate for more compassionate, evidence-based healthcare policies. Next up, Andrew Longhurst, a senior researcher and political economist at the Canadian Centre for Policy Alternatives, where he leads the health policy desk. Andrew has over 40 publications under his belt on topics like healthcare finance, primary care, surgical wait times, and privatization. Last but not least, we've got Dr. Yasin Cholikov, an assistant professor at McGill University's Department of Global and Public Health. He also works as a public health physician at the Nunavik Regional Board of Health and Social Services, where he supports infectious disease surveillance, outbreak response, and public health policy across 14 remote Inuit communities in northern Quebec. Thank you all again for being here. So let's start off with an introductory question. Can you each describe the main health policy or the main health issue you're concerned with in your jurisdiction or area of expertise? Let's start with Ryan.
Sure. Hi. Thank you for having me, and what a pleasure it is, I'm sure, to be addressing such a keener audience if you've logged into this. I mean, for myself and for my organization, we primarily work in the area of addiction, so substance use policy. Most of our patients, or many of them, struggle with substance use disorders, so that's our primary focus. Having said that, I mean, that is kind of a lens into what's going on more generally with increasing what we would call political interference in the practice of medicine. So although sometimes that begins with substance use care, you know, we've seen experiments, if you will, with provinces trying to clamp down on gender affirming care, MAID, and you know, other policy areas. And so from our perspective, this is really just the canary in the coal mine when we talk about how people with addictions are treated. We see this spreading to other areas of healthcare in the near future.
Thank you, Ryan. Yasin?
I would say that from the setting where I work, I think the main issue would be ensuring equitable access to care for all populations. So that's an issue that in my day-to-day I see, specifically working in Nunavik, where a lot of the care, where there are small communities and patients receive care that is sometimes subpar of what we would expect for the Canadian health system, and where sometimes the local epidemiology justifies different packages of care and different services that are not made available or made available through incredibly complicated hoops for the population there. I would like that to be something that is addressed.
Thank you. Let's go to Chris next.
Yeah, for us here in Alberta, it's obviously the existential threat we're facing to single payer Medicare in Canada with the bringing in of two-tier healthcare. Alberta set to start in September, so the clock is ticking. We have a government that has passed three major pieces of legislation, health statutes amendment acts, in the last year, and they bring forward things like private hospitals, private diagnostics, pay out of pocket healthcare, and most concerningly, in Bill 11, full on two-tier healthcare system, which prioritizes insurance companies and the ability to sell insurance products for medically necessary care instead of our single payer Medicare plan that we rely on. So really, it's this kind of existential change to healthcare delivery and financing we're seeing in Alberta.
Thank you. And last but not least, Andrew.
Yeah, I will echo Chris. I think really we are at the most significant juncture in terms of Canadian Medicare, public health care in this country, with the very real plans, as Chris said, by September, a two-tier system will be in place in that province. And then I think by extension, we're seeing a lot of provinces, while they have not explicitly legislated two-tier healthcare, many provinces allow private for-profit companies to operate by charging user fees in contravention of the Canada Health Act, and those provinces continue to do so. And provinces like Ontario and certainly Quebec, where it's been underway for longer, have a large and growing private for-profit industry providing contracted and private pay surgical services, diagnostics, increasingly virtual and primary care. And so what we are seeing is the building of this quite significant industry is really sort of the appetizer to a two-tier system. Governments contract with these providers, and then, like in Alberta, they're now flipping the switch to explicitly legislate two-tier healthcare.
Thank you. We'll talk more about privatization in a second, but just for the next question, if you could each have one health policy implemented in your jurisdiction or federally across the board right now, what would it be and why? Let's start with Yasin.
I'll answer both locally and federally. I think at a local level, ensuring that the health system is financed on a needs basis. So ensuring that the needs of the health needs of the population are filled and that the resources to do so are provided by the health systems is what would be most important, rather than ensuring kind of equality in some of the systems where equality does not actually lead to the same outcomes in more complex settings. And at a federal level, I would say improving. We're at a moment where there's a good opportunity for improving data sharing and also improving clinician mobility, things that would integrate the Canadian health system and help it be more closer to one health system where patients would have an easier time when they're moving around for healthcare, but also moving around for life events. There's currently bills being discussed at the federal level to improve data sharing, including the Bill S5, Connected Care for Canadians Act. So those are things that I would like to see kind of come through and help us build a stronger Canadian health system rather than many jurisdictional health systems, which is the current situation we have.
Thank you. Let's go to Andrew next.
Well, I would like to see us enforce our existing legislation as a starting point. Right now, we're not seeing the Canada Health Act being enforced by the federal government. And this is leading provinces like Alberta to flagrantly violate statute with apparently no consequences yet. Or at this time, we haven't seen any indication from the federal government that there will be consequences, which is of grave concern. So I think that would be my initial response. But I would like to see, since the pandemic, the early days of the pandemic, we talked a lot about the necessity and urgency of improving long-term care. And I think, unfortunately, we've lost momentum in that regard. And so having national standards for long-term care in this country, which are not part of the Canada Health Act, and there has been movement for legislation in parallel to the Canada Health Act that brings it into the public realm and ensures that there are consistent standards across the country.
Thank you. Chris?
Beyond what others have said, both in Alberta and across the country, what we desperately need is a workforce plan for healthcare. We have a booming population here in Alberta. We do not have the skilled health professionals, doctors, nurses, allied health that we need to provide the care to our population. That's why we're seeing such an issue with access. That's why we're seeing markets pop up for two-tier healthcare because of long waits. People are willing to find ways to pay if they can. And what we really need to solve is our workforce issues rather than the path we're going down with two-tier healthcare will only make them worse. But we don't have any sort of workforce plan in Alberta. We haven't mapped out the workforce versus the population. We don't have a retention strategy. We don't know who we have working where, let alone recruitment or connecting that to training and post-secondary and so on. And then that needs to happen across the country so we're not just poaching from each other with incentives to get people to move a province or two over to come work, but actually have a plan for healthcare and the workforce in Canada.
Yeah, good point. And Ryan?
Yeah, I don't want to in any way take away from the dire alarms being raised here, but two-tier healthcare. Having said that, it's not a competition, and I'm here to bang a different drum today, of course. So I'll point out that we are in the biggest public health crisis in our history, right? It's taken more lives than AIDS, it's taken more lives than COVID, and it continues. It's not over, and so not to diminish anything that we need to do with regards to enforcing the Canada Health Act and so on, but I mean, the Public Health Agency of Canada, through public health law, has enormous power. They could regulate the toxic drug supply tomorrow if they wished, and they've chosen not to for 10 years that they count and a few more that they don't. So it's really simple. I mean, the federal government, either in concert with the provinces or on its own, could regulate the drug supply. And I highlight that because of all the terrible outcomes we can contemplate, it's hard to get past the brass tacks of deaths. That's the ultimate negative outcome, of course. And there's only really one way that you're going to dramatically reduce the number of deaths we're having in this public health crisis.
Thanks, Ryan. And let's talk a little bit more about privatization as well. I mean, it does also affect the toxic drug crisis in provinces that contract out to private companies for treatment facilities, for example. It's a phenomenon that's creeping into Canadian public health care in different ways depending on where you are. So I want to know, what are the differences or similarities between the way that Alberta is privatizing healthcare and how other provinces like BC, Ontario, Quebec are or have been doing it? Let's start with Chris.
Yeah, and just to leap off Ryan's point, the drug poisoning crisis and what we've done to mental health and addictions in Alberta has been the gateway to massive privatization. What the government's done with Recovery Alberta and their ideological approach to, recovery-only care and so on is absolutely about a private for-profit recovery industry coming in and taking over our addiction services that should be healthcare. So it's an important point. But what Alberta is doing differently than all the other provinces right now is within Bill 11 that they passed, where they're allowing for what they call dual practice, which means doctors can switch back and forth between private and public systems, patient to patient, day to day, service to service, which is not allowed anywhere else in the country. Even in Quebec, where they've had a whole bunch of doctors opting out of the public Medicare plan, they have to choose. They can't just go through their day, decide who to bill, who not to bill, and make as much money as possible for that way. So it's a massive change to having two streams with a two-tier healthcare system. And within Bill 11, the majority of the legislation is actually about insurance and allowing for workplace plans to start selling products and so on. So really what we're seeing is this American approach that insurance and the ability to pay will determine what care you get, and there'll be a rump of a public system left. And they're making it as easy as possible for physicians and others who are working in healthcare to make as much money as possible by being able to do this dual practice system. So it's fundamentally different than any other province allowed.
Thanks, Chris. You mentioned Quebec, so let's go to Yasin next.
Yeah, it's a complex conversation in Quebec. I think that Quebec has a longer history of having this sort of private pathway of medical practice. But at the same time, I think it's also important to distinguish the private delivery and versus the private financing. A good portion of Quebec's private so-called system is publicly financed private delivery. So patients are still not paying. And then there's what's now unfortunately growing, the really truly private, where patients are the ones that fork up the money, and the patients, the people who can afford it, are the ones accessing that care. So essentially eroding access in the public system and creating faster pathways in private systems. This being said, I would preface kind of the conversation here with the fact that the province has taken in the last many years a very antagonistic approach to negotiating with physicians, which I think has been to the detriment of strengthening the system as a whole. And that antagonistic approach kind of culminated last fall. You would have seen in the news lots of those negotiations, protests by physicians. And essentially, now that things are somewhat resolved and things have concluded, we're still at a place where many physicians have chosen to leave, and leave in many different definitions. Some have left the province, some have decided to leave the public system in order to be further away from that locus of where there is a strong government influence in what their practice is and how it is to be done, and including in ways where they were sometimes facing ethical dilemmas, where they were told to do certain things and they felt that that was not the best quality of care that they could provide, because they were forced to do volumes that were greater than what they could manage to provide quality care. A greater number of patients, for instance, they could provide quality of care, or forced to take on patients beyond their capacity in certain settings. So I think that when thinking at a systems level, it's important to find ways of strengthening our system and learn from other systems, other public systems that are doing well, and doing well while also finding ways of ensuring that all the practitioners in the system are valued and are happy to work in it. In Canada, to a large extent, we're burning through our healthcare workforce, not talking about physicians here, but across the board. We're asking them to work a lot of hours, and we're overworking them. And different people in that, different professionals have different kind of capacities to negotiate, but in all situations, they're very much overworked, and we've got to find ways to do better. And one last point in this conversation also, if we compare ourselves to other settings, we have we are asking our healthcare workers to work a lot more hours. And in many contexts, despite the fact that there is privatization, the major healthcare employer is the public sector. It's essentially a single or a compound, a group of similar employers that belong to the public sector. And in those situations, I think that we have to be careful to not overstep certain boundaries where we consider healthcare workers as a special class of workers that do not have to have their normal rights protected, their right to move, their right to take breaks if they're feeling unwell, something that we do for public health reasons for all other workers, where unfortunately we sometimes choose to exclude healthcare workers and sometimes choose to exclude specifically doctors who are usually not in employment, not in direct employment contracts as other workers. Yet there are ways to do things differently. Like most of Europe functions in somewhat public, in more or less public healthcare delivery systems, and they do not face the same restrictions to basic rights of those employees or those workers. Yeah.
Thank you. Yes. And Ryan.
Thanks, Brishti. I think I'll skip this one. Actually, I don't think I have anything to add compared to your experts on this topic, so leave it there.
Sounds good. Let's go to Andrew.
Thanks. Yeah, it's important to distinguish different forms of privatization. And as Yasin said, there's private for-profit delivery of services through government or public contracts, and then there's private pay or private financing. And I think what we are seeing and have been seeing for a number of years now, and it's really kind of been at the core of my work over the last decade or so, is the blurring of those boundaries. And I think what we are seeing in provinces, certainly like Alberta, but a province where it had built through government contracts, public dollars, private delivery of surgeries and diagnostics, and and other services as well. But building up that private industry, and then the movement now towards explicit two-tier healthcare, which is the private financing portion. So taking private payment from patients either through out-of-pocket payments or through private health insurance, which, as Chris mentioned, this is actually, I think, the most important part of what is happening in Alberta, and what those that want to dismantle public Medicare in this country are seeking to do. They want to create a large enough private health insurance market where you start to see greater and greater movement of private insurers into financing basic healthcare services that are already covered through our public and provincial health insurance plans. So yes, we have these two forms of privatization. Increasingly, I would argue those distinctions are being blurred. I think they're being blurred on purpose because a lot of the same corporations, as well as some of the surgeons and physicians working in those facilities, are engaged in both publicly financed, contracted privatization, as well as increasingly private pay, two-tier healthcare. And I think this is the challenge: is the farther that we go down this road, the harder it is to put a system back in place where the challenges with regulating it, much like we see in the United States, where you have a very large for-profit healthcare industry, that the distinctions between private healthcare insurers and private hospital chains and private providers is actually less important now in the United States, because many of these large mega corporations are vertically integrated. Some of the largest corporate hospital players sell private health insurance. So I think these are the things we have to grapple with. And most importantly, now at this geopolitical moment where this could very well be the backdoor into undermining our very Canadian sovereignty, by unleashing private health insurers and corporate hospital chains, private equity chains into the Canadian healthcare market. This is an untapped market, and this is the language that U.S. Private equity investors and others use. That market is increasingly tapped out. That's why a lot of these interests are looking to South America. They're eyeing Canada. So I think it's a very real threat. But I did want to really highlight the fact that we are seen as a place where predominantly we have a publicly insured healthcare system where payment for those services is paid for by provincial health insurance plans. And this is the thing that right-wing interests and corporations, and certainly those in the United States that have an interest in what's happening in terms of the separatist agenda in Alberta, these are plays that they seek to make. And I think we need to be very live to the fact that public health care is a way to undermine our sovereignty, and it's also a way to see increasing and widening health inequities. As you see access to healthcare defined based on how much you have, who you are, where you live, those health inequities will widen, and that's exactly the story that's been playing out for decades and decades in the United States.
For sure. And, it's ironic because one of the biggest arguments made by people in Canada who are pro-privatization is the idea that it will improve access to care because our current system is not working. So let's talk about that. And let's go into inequities in access. So what is the difference between access to care, whether we're talking about addictions care, long-term care, outbreaks, or just access to a physician for routine health checkups? What is the difference between access in urban parts of the country versus in rural and Indigenous settings? And is this disparity something that does or should concern the federal health ministry? Let's start with Yasin.
Yeah, I mentioned it briefly at the beginning that I do see very large differences in access to care for things that should be kind of primary care in Nunavik, when compared to regions like Montreal, where certain conditions are much more rare, yet people get easier and faster access for care for them. This is particularly true when we're talking about tuberculosis outbreaks that are happening on a regular basis, and when people, unfortunately, from Nunavik have to sometimes fly out to get very simple things done, like an X-ray or things that would take 5 minutes, end up taking them 2 days, 3 days, sometimes travel, and things that would not be impossible and would likely be cheaper to deliver locally rather than having to move people around and disrupt their lives and yeah, and make things more complicated for everyone, including for health systems. It's just that, unfortunately, kind of the incentive of ensuring that that appropriateness of care and the capacity of the health systems to readjust and fine tune things is not always present and sometimes hard to find. And I think an important point when talking about inequities more broadly, not just inequities in access to care, but inequities at large, is it's important to keep in mind that inequities in society are associated with negative health outcomes. So the more inequitable society we have, including in access to care, the more bad health outcomes we have for everyone, including the better off people that will actually suffer the impact of having that inequitable society. So this is something that should be a priority at all levels of government, both provincial health systems that are responsible for the day-to-day delivery, but also the federal government that's responsible for some of the resource transfers and some of the priority settings. And like we said earlier, kind of ensuring that some of the principles of our public system are respected across the country.
Thank you. Ryan.
Yeah, I mean, every level of government in Canada knows this, that there are massive disparities in outcomes for people who live in rural areas versus urban, and then even more so, you know, in various Indigenous communities. And of course, when you're talking about Indigenous communities, there's more going on there than just geography. But it is, honestly, geography is a big part of it. I mean, we've seen all provinces engage in this process that sometimes gets called regionalization for decades now, where, you know, they either close rural hospitals or reduce services at them and concentrate those services, you know, in what they would view as like one, you know, the only necessary regional hospital, right? We see this particularly acutely for labor and delivery, right? Where people giving birth are having to travel further and further to access safe birth if they can't safely have a home birth or what have you. So, I mean, I don't know what to say about it. It's not news. You know, no amount of like new data or reporting is really going to make this more clear. I will say that, at least in BC, we have kind of an embarrassment sensitive government, which not everyone is lucky enough to have, right? Like some governments don't care, but ours doesn't care, except you can embarrass them. And so, you know, when it's pointed out that their policies, you know, have a negative impact, let's say on Indigenous rural communities, they care about rural voters and they will respond to that. We saw a bit of a partial climb down on, just to use my example, a partial climb down on restriction of safer supply prescribing because stink was made about it in the media. You know, which just goes to show that, again, that they already know, but they, you know, if someone bothers to call attention to it, maybe they'll act on it.
Embarrassment prone government. That's a great point. Andrew.
Brishti, you'll have to remind me the question.
For sure, yeah.
I was chuckling away to Ryan's comment.
Fair enough. What is the difference between access to care in urban parts of the country versus in rural and Indigenous settings? And is this disparity something that does concern the federal health ministry?
Well, it should, and you know, we have lots of reports. We have lots of a history of governments, at least performing that they interest and displaying it, but not necessarily acting on it. I think one of the fundamental challenges is coming down to the highly decentralized nature of healthcare in this country, right? We have provinces and territories that pursue health system design and reorganization and delivery with a great deal of freedom. And often, I mean, we're seeing this acutely playing out in Alberta, and we're seeing other provinces pursuing not necessarily evidence-informed strategies to improve access to care and improve outcomes and close those health gaps. And I think not to continue on the thread of privatization, but I will. The focus on a lot of these players and motivations, these markets are primarily concentrated in urban centers where volumes of procedures are profitable. Again, a lot of the interest is in the low complexity, low acuity patients and procedures, the kind of assembly line cataract surgeries, knees and hips. These are not areas where, like primary care, like all of the other aspects of the socioeconomic determinants of health that come outside of the healthcare system itself, like housing and income support and so on. All of these things are going to get worse as you focus your policy energy on strategies about increasing a market for healthcare services, where these services are concentrated in urban centers. The explosion of a lot of these for-profit facilities and initiatives are focused squarely on these, again, low acuity patients, high volume procedures where they are profitable. And that's also, again, what private health insurers look at. They're not, we know that from data in the United States, things like mental health is not a profitable area. And yet this is an area of huge unmet need in this country because it's largely excluded and not covered under the Canada Health Act. Good, strong primary health care in this country, we need to see movement on that because it has the potential to reduce health inequities, but also reduce costs in other much more expensive parts of the system, like hospitals. So all of these areas are not going to be served, especially in rural parts of the country where you see these disparities in their most extreme. It's not going to be solved by a focus on increasing public dollars that flow to funding private for-profit cataract surgeries. It's simply not going to move the dial on closing those health gaps. And so I think as provincial governments, many of them are focused on this policy direction. We're unfortunately getting further away from the goals of closing those health divides that exist based on where you live, your social location, whether you're Indigenous, whether you are a newcomer to Canada, whether you are living in substandard housing. All of these issues are not going to be addressed by a push towards increasing a market for healthcare. And in fact, they're going to be exacerbated by it.
Thanks, Andrew. And finally, Chris.
Yeah, it's important to remember that it'll never be profitable to deliver healthcare to rural communities. So if you live in a rural place, you might want to think about that as we move down this two-tier system, because it's never going to be a good business opportunity. But in terms of the access to care, especially here in Alberta, we recently completed a 25 town hall tour across the province, 25 stops. So we were in urban, rural, suburban, north. We were all over the province talking to people in their community about access to care. And that is the number one concern, regardless of where people live, is access to care, access to primary care, emergency care, surgeries, cancer care, and so on. But it looks very different depending where you live. You know, in Edmonton, you might be concerned that you had to spend 10 hours in the waiting room with your child at the emergency room to get in to see someone. But then you look at the map of closures across Alberta, and on any given day, there's 20 temporary closures of emergency rooms and other services all over the province, where communities have nothing in their community open because there's staffing challenges. And a good example of that is obstetrics care, where in most of the north, you can't really have a baby. In Alberta right now, you have to have a plan to go to a city or a scheduled C-section, because the obstetric services are just constantly temporarily closed, including places where they've been temporarily closed for over a year. So at what point is that just a closure? We would debate that, but that is the reality. And then if you live on a First Nation or a Métis settlement, it becomes even more challenging. Often there isn't the own services for healthcare, or it's funded through the federal government for some of those communities, or it's a different structure for accessing care. And we have a problem in Alberta, and I know you've written about this, Brishti, is that we have this treaty right to health in theory, but when it's not being met, and we try to raise concerns like about vaccine rollout, for instance, the federal government and the provincial government just point at each other and blame the other person and don't actually solve the access issue for people that have a treaty right to healthcare that isn't being met. And so as we see this staffing issues and the closures and so on move forward, and then this two-tier healthcare system, we're deeply concerned about what that means for people living on First Nations, especially in the North, if their ability to access care becomes a financial obligation, and we have governments who won't even agree on who should be paying for what services or where they should be delivered. So, it's a snowballing impact, and it isn't impacting everyone equally as these changes are happening.
Thanks, Chris. Some great insights from your town halls as well. Appreciate that. So, on the issues that you've each described, what would it take for the federal government to step in more materially and improve access in the places and issues in which it's lacking? Let's start with Andrew.
I think we need to see a greater focus federally on primary healthcare, and really recognizing that a lot of the policy interventions taking a primary healthcare approach requires that we think about all of the upstream determinants of health, whether that's housing, whether that's income support, whether that's education, quality childcare and public services. Many aspects to food, nutrition, all of these things that shape health outcomes. And so I think in terms of the federal government's role in primary health care, under the previous federal government, the Trudeau government, we did see some action towards targeted bilateral agreements for primary healthcare services. I think it was, in my view, still did not have the strings attached that it needed to, and this is a consistent theme that we see federally and with the nature of healthcare federalism in Canada. I think we need to see continued focus in that area, and there's been a lot of momentum and work in that regard from clinicians themselves to communities and from those that are on the front lines of providing, I think, excellent care. The community health center model in this country really exemplifies a primary healthcare orientation, which understands that health is not just what happens in the consultation room. Health is all encompassing. And so you need to think about housing, income, all of these pieces that play such a crucial role. But I also think back to this point about the tendency of the federal government to be so reluctant to compel provinces to take leadership. I think we have increasingly with the dynamics that are playing out in Alberta between the federal government and the Alberta government. I think right now we unfortunately have a federal government that is less likely than the previous incarnation to really take strong leadership in the areas where it's needed. And I think we need to really push as communities, as citizens, as frontline healthcare providers, collectively for greater federal leadership, because I think people ultimately want that. We see public opinion polling showing desire for having national standards across this country for healthcare. You shouldn't have differential access to healthcare. You shouldn't, as we know, have differential outcomes and wide disparities based on where you live, and yet it persists. So I think we need to see a much more visionary, and I think a larger role for the federal government to move in that direction of recognizing that we not only need to enforce our existing legislation, including the Canada Health Act, but we need to think about what health and what healthcare means in the 21st century. And right now, Canada, unfortunately, has been really kind of behind a lot of other peer jurisdictions in its focus on nonprofit primary healthcare and ensuring that those services, but that broader orientation is consistent across the country.
Thanks, Andrew. How about Yasin?
Yeah, I would say that it's important to kind of fall back on exactly the Canada Health Act, making sure that that's respected. And I think it's also important to be careful in the framing of the conversation. When we start talking about privatization, we're starting to talk about the value and investment in healthcare. But I think if we go back as to why most advanced society have chosen models that are more public than private for healthcare delivery, is that because healthy populations are an economic motor as well. People go to work. Healthy populations require less other investments beyond health to support them. So keeping the population healthy is and should be a priority in order to ensure the continued economic stability and growth of Canada as well. So I think kind of reframing the argument around that should be a priority for provincial and federal governments alike.
Thank you. Ryan?
Yeah, I mean, obviously, enforcement of standards, as others have mentioned, is key, and I would sort of tie into that, a robust understanding of the Canada Health Act to include mental health and addictions care in those standards. Chris mentioned, the sort of private addiction medicine or addiction treatment system in Alberta, but really it's like that across the country, just to varying degrees. I mean, for some reason, maybe a historic accident, we've decided that getting treatment for substance use disorder is largely a private affair. And, the problem with that is there are no standards. There's absolutely no standards, no data tracking of what happens when someone leaves a residential treatment facility. I can't confidently say to my own patients, in general, if you go to residential treatment, this will help, you'll get better. It might, you may, but there's no standards. I have no window really into ensuring that what goes on there is evidence-based and of a high quality. So, the federal government could say, look, provinces, you're not regulating this, so we're going to do it for you because people are potentially being harmed. People are being harmed, depending on where they go and what occurs there. And then beyond that, I mean, in my little, again, subject area, I mean, there was this great thing called SUAP, SUAP. It was federal grants for all kinds of innovative addiction treatment programs across the country. I mean, a lot of the closure of services you've seen in Ontario, for example, was enabled by the federal government pulling its funding first and then the Ontario government following up and pulling funding second. So the federal government was, for a window of about 5 years, though, keeping a lot of innovative life-saving programming alive, initiating it, in fact. And it was a rounding error in the federal budget, but it was life-saving for many, many people. So that's an easy thing they could bring back and, in fact, expand.
Yeah, great point. Lots of supervised consumption site closures across this country. Thank you. Finally, Chris.
Yeah, I think in terms of a federal government, we don't have a federal government right now that wants to talk about healthcare. I think that's a major concern. They almost never acknowledge it exists. You almost never hear from the federal health minister on anything. So like the bare minimum for us is enforce the Canada Health Act, which is the law and their job as the minister to enforce it. They could keep their own promises on things like pharmacare and dental care rather than attacking their own programs that they ran on. That would help in terms of access to care. But it's really that leadership piece that Andrew was talking about. We need our federal government to see themselves as having a role in healthcare. They're a major funder of healthcare across the country, billions of dollars. We used to have a system where, we had things like a health accord where the federal government showed leadership with the premiers to actually negotiate what outcomes we want to achieve. We could have stuff like that again. We could have a federal government that sees that they have a direct role in the drug poisoning crisis and long-term care standards, in terms of access to reproductive care. They really could do a lot if they saw themselves as a leader, which includes being a major funder. Just in Alberta, we get over $7 billion in the federal health transfer. They have a lot of leverage if they would choose to bring people together and have that leverage. And then just the final piece is recognizing that they actually have a very clear treaty obligation to health, and that recognizing their role in that, especially here. And I'm in Treaty 6 with the medicine chest clause, but on the prairies where we have numbered treaties, they have a clear role, and they really just leave it to the provinces in so many cases, and that's not good enough if we're actually talking about access and equitable access to care.
Thanks, everyone. That is all the questions that I had. We do have a number of questions from the audience, but before that, I just wanted to open it up and ask if there's any key takeaways from this discussion that any of you want to share, or anything else that you want to add. And I'll leave that to anyone that wants to go.
I'll just jump in and add something that I haven't talked about, and that I think is really critical as it connects to the workforce. There has been internationally a movement towards health system improvement and quality improvement that has really it's been credited for both improving outcomes, but also improving recruitment and retention and job satisfaction. And what it really requires is a movement away from very top-down, highly bureaucratic ways of working towards ways that harness the energy, the commitment, and the joy in why people go into work in healthcare in the first place. And one of the jurisdictions that has been leading the charge in this has been Scotland, in terms of their focus on quality improvement and their commitment towards social solidarity, understanding public health care as social solidarity. And I think at times where we can feel like we're lacking hope and a bit frustrated about where things are at, I think it's important to recognize that there are examples where governments have taken strong leadership, and they have recognized that they need to really harness the energy, the passion of frontline providers and their commitment to a healthier population. And I think it really speaks to, in a lot of parts of the country where often, the workforce is the last engaged in health system redesign or changes, and yet they should be the champions. They should be the ones leading improvements. And those are the ones that have the staying power. When you harness that energy, that insight from those who know how to do things and improve things, you are going to see better results. And that really is also a key to recruitment and retention. If you feel valued in the work that you're doing, you feel like you have a stake in it because you are heard, you are respected, but it requires different ways of working that often we're not seen in a lot of our health regions and health authorities across the country. It's a much more worker and person focused way of leading and governing health systems. And I think it's one that we can look to other jurisdictions, and we can also look, as I mentioned, to the community health center model. It's largest in Ontario, but it really, I think, encapsulates that passion, that understanding that the front line has a significant role to play in leading the charge in improving population health, and we need to ensure that the workforce is right there in championing that work.
Thanks, Andrew. Any final thoughts from anyone else before we go to questions? No? Okay. Great. Andrew, I know you mentioned Scotland there, and there was actually a couple of questions about other jurisdictions. One of them mentioned Scotland. But the overarching question seems to be, in your opinion, what countries are ones to be emulated to avoid privatization and improve healthcare quality? And open floor, anyone?
Not really my wheelhouse, but I mean, it always seems like Northern Europe has it best, especially Scandinavia, but that's just my vague impression. I mean, where this conversation gets tricky is that people, maybe someone else could answer this, is people always argue, oh, but these countries have like a 10% private pay system, and they use that as an argument for why we should have a mixture. And I'd love to hear someone else's answer about that.
I'll just jump in to say quick, and I know Andrew's researched all these countries, but what we're emulating here in Alberta is American healthcare. And we hear a lot of like, look at Europe, look at these places from our government. But just to be explicitly clear, we are looking at a two-tier system where insurance companies are a key funder of the care and private delivery is key. So we're not talking about any of those jurisdictions, but we always have to be careful in those comparisons because we're never comparing apples to apples. It's the different systems built on different structures over a different history. But we actually spend a lot on private care in Alberta already. We spend more on private care than a lot of those countries. So, I think we have to be cautious about people throwing out comparisons to try to justify what they're doing. People being our Alberta government is who I'm pointing to. But there are obviously places to look. You can look, to countries with better drug policy. You can look to countries like Denmark and how they're treating seniors care, but we're not looking at those solutions. Here in Alberta, we're looking at specifically allowing people to pay for care and allowing insurance companies into our borders. So we're not having that discussion, but there's lots to look at, and I'm sure Andrew has more to.
I'll jump in very quickly. I mean, just to say, Canada compared to much of Northern Europe spends a much larger share privately. So healthcare is privately financed to a larger extent. It's about 30%, 29%, as opposed to you look at some countries like Norway, where only 14% of total healthcare spending is financed privately, is private pay. So a lot of these jurisdictions have actually a much broader publicly financed healthcare system where seniors care is not an afterthought, where primary care is not so limited in the way that it's conceived here in much of Canada, where again, mental health and substance use services are not seen as an afterthought. So I think it's just important, as Chris said, that when we look at those models, those are also jurisdictions that have done more to increase tax fairness, have maintained greater equality within society. And there's a large body of literature that Yasin referenced where equality is actually better for everyone, even the wealthiest in society, because outcomes are better. So I think it just underscores the fact that we need to look at what is being done successfully in a lot of other parts of the world. But right now we're getting, by way of Alberta, picking up these slices of different countries that aren't reflective of their overall experience.
Maybe to jump into a couple of elements, I agree with everything that was said thus far. I think Northern Europe is a great example. I think kind of looking at the current situation in Canada, we may also benefit from looking at examples of systems that have universal mandatory private insurance systems that start looking a lot like what we have with single payer systems in Canada, just to be able to track different pathways of evolution of current systems. So thinking here of Switzerland, Germany, which in the end the health system looks quite a lot like a single payer public system, with oftentimes progressive financing of the healthcare system by the payers who use the majority of payers who use the insurance schemes, and the majority of payers end up in the kind of the government highly regulated insurance scheme. So I think that's the key point here is if there is privatization, it needs to be highly regulated, not completely deregulated and free for all. That's the one way where we can actually have some small elements of private systems while still maintaining a strong overall healthcare delivery system. And the one kind of comment on Scandinavian systems, I think what's interesting there is also that all of those systems have extremely good health information infrastructure and the capacity to monitor the health of their population and adjust needs on a relatively small locality basis, and make the resources that are necessary flow to the places where they're necessary. I think this is something where, again, in Canada, we could improve.
Thanks, everyone. Yasin, you mentioned regulation, and we do have one question, kind of phrased as a statement, but it is a question. Regulation seems to me to be the main key to improving Canada's healthcare, and this should also be enforced nationally as per Canada Health Act. Insurance should also be regulated, question mark. So I think what they're asking is, should insurance be a regulated industry in Canada, and to what extent is it regulated?
I would answer yes, but it's not an area of expertise. I would say what I know of systems that have, like I was mentioning, European countries that have universal mandatory insurance, to a large extent, the insurance policies are extremely comparable to one another. So they differ on minute details, whether you'll get some sort of coverage for certain small things that are not the core healthcare delivery and that are more, I guess, optional things, whether you'll get like nicer meals covered if you're in a hospital, private meals covered, things like that, things that one could debate are maybe actually extra luxuries that you're getting covered through a special scheme. But the whole health delivery is covered the same way through all the insurance schemes, and people pay in a progressive manner based on the income they're making to those schemes. That's the kind of high intensity regulation for private insurance that is seen elsewhere in places which have equitable healthcare delivery despite elements of private insurance systems. I don't think that we have all the elements that they have in those jurisdictions here in Canada yet.
Thanks, Yasin. We have a number of questions that kind of follow a similar vein. Generally, people are asking, what can we do to push governments that won't the governments to act that won't get us arrested? Number one, what are effective ways that we can pressure the federal government to, follow the Canada Health Act, and what has worked in the past to pressure the federal government to act against a rogue province? Maybe Chris or O'Brien, go ahead.
Well, I was going to say, I mean, I don't know this person's personal circumstances, but, consider getting arrested, first of all. Why not? Like, I don't think that, again, I mean, I'm sensitive to people's personal circumstances, but civil disobedience, honestly, is historically one of the things that moves the ball. And I, to an extent, agree. I mean, governments do sometimes weigh their decision making based on the number of emails they received for or against something, and that's worth considering. I mean, there is strength in numbers, but if that's not working, I mean, why not civil disobedience? That's probably where this needs to go. So yeah, let's get arrested.
I think a couple of things based on just looking at some of those questions. Historically, the federal government has stepped up on their own to enforce the Canada Health Act, to speak up in favor of it. The Canby case from BC, where they came forward in a very strong way in defense of the Canada Health Act and universal Medicare. We're not seeing that in this case currently. So we are putting on that pressure to the federal government to say, enforce the act. It's been your stance forever. In the past, they've done clawbacks to rein in provinces or threatened to do them. Even Stephen Harper threatened the potential of health transfer clawbacks on Alberta at one point. So we're needing to see that leadership again, because that is a tool that the federal government has. And I know some people in the questions were asking about legal options on that as well. It's important to know, because we haven't actually started the schemes under Bill 11 for surgeries. They don't start until September is the government's timeline. They haven't actually broken the law yet. They've just passed legislation and are implementing a program that will violate the Canada Health Act. So you can't actually go to court to stop them from doing it before they've done it, if that makes sense. So we just know it's coming. So there is that kind of nuance. I saw some legal questions attached to some of these questions about it. But really, we have a political problem. It's not a courts problem. We need people to get engaged. And that's why we toured the province. We're starting up chapters throughout the province to do work locally, because we have a provincial government that is happy to ignore us as long as possible. But in recent weeks, they've backed down on 3 different public healthcare policies that they'd announced, and then they reined back in from public backlash. So they're not totally immune to public feedback. And what we know from both public research and polling and from touring the province is that the vast majority of Albertans, no matter how they voted, don't support a 2-tier healthcare system. Our government didn't run on it in the last election. They actually ran on the opposite. They ran on a public healthcare guarantee, not blowing it up. And when you tell people what's happening, they're upset by it. So for us, it's a matter of getting on the ground, grassroots, mobilizing, reaching as many people as possible to tell them, this is what's happening. Do you agree with it? If you don't, this is the moment you need to do something about it. And so that's what we're doing all through the summer as well. So to us, it's about an on-the-ground organizing response that we need to see. Because when you ask people, the vast majority of people don't really know what's happening. right? So we have to get out there and get to them. That's really our approach, right?
Thanks, folks. We have quite a few questions. I don't think we're going to get to all of them, but I'm going to go with one more. And this one is about privatization. So, often people are not choosing private healthcare because they oppose the public system. They're turning to it out of desperation. People pay for life-changing surgeries because waits are unbearable. How to make a compelling case against privatization that acknowledges those realities without blaming people for seeking care? What does an effective, hopeful fight for public healthcare look like when the public system is failing so many people? Andrew, do you want to take that?
I'll take a stab at that. I think it's a really important point to make that for many people, just like folks who, for various reasons, seek out private education. If the public school system is not meeting the needs, maybe they have a child with a disability. There are lots of examples about why people make certain decisions, and in healthcare, if you're not getting the access you need in a timely manner, of course, you're in a position where you may be left with few options. But I think it does come down to really understanding why the public system is not meeting people's needs. And for example, a recent report that the CCPA published looking at hospital spending in Ontario, and the fact that we are seeing a very purposeful move by the Ontario government to underfund that system, which is leading to emergency departments failing to remain open. It's leading to longer wait times for necessary care. I mean, these are political decisions that have very real consequences on people's lives, and they encourage a growing market for private pay healthcare. Let's make no mistake about that. That's what the effect is. So I think we need to understand and we need to identify what are the policy decisions and political decisions that are leading to people having to seek out private healthcare. And I think really understanding and talking about what those problems are and advocating and advancing the evidence-based solutions that would get us to a place where everyone is getting the care that they need in a timely manner. A recent research study published in the CMAJ found that if the Ontario government moved to a single entry model or a centralized intake system for orthopedic surgeries, everyone in Ontario would be getting their surgery within the clinically recommended wait time. So it's not that we don't have the solutions in front of us. There is a lack of political will to implement and act on those solutions, because I think in some cases governments are very wedded ideologically to a direction that is not in the best interests of Canadians. It's not in the best interests of patients, but it is a highly profitable direction for a handful. So I think identify why people are being forced into these situations and advance the progressive public policy solutions that we need.
And I'll add to that for a moment. It's a long used political strategy. You break it and then you privatize it when it comes to public services. So let's not pretend there's not a political agenda at play as these things are happening, as the system is failing to meet access needs. These are choices that are being made. But I think it's important to remember that the only way a two-tier healthcare system is profitable is if there are long waits, because no one would choose to pay tens of thousands of dollars for a surgery or for their diagnostics or to buy insurance products to skip the queue if there isn't a long queue. So we're actually baking in a system where if we're going to have a two-tier system, there has to be an incentive to get people to choose to pay as part of that. So really what we need to be looking at is the solutions in the public system that exist to bring down the wait time so that everyone gets the care in the medically required time, because otherwise there'll be no incentive to ever solve the queue in the public system, because if we did that, nobody's going to go pay for these private health products or these private insurance products or just directly pay tens of thousands of dollars for a surgery because they wouldn't have to. right? So they're actually building a system that requires long wait times for it to be profitable. And it's a political strategy. And the insurance companies are actually bragging about how they're working hand in hand with the Alberta government to implement this. They're not ashamed of what they're implementing. They know it's going to be good for them and their profits. It has nothing to do with wait times or what will be good for patients or Albertans here.
Thanks, Chris. Does anyone else want to weigh in on that?
I guess the other thing that brings to mind for me is that what someone who's in that very, maybe we can all empathize with, that very difficult situation of not being able to access care, is that what they are imagining in the abstract is probably not the reality. They're probably, that person is thinking, look, I'd pay a couple $100 for X, whatever it is, right? But that's not the reality. I mean, the reason we don't actually see droves and droves of Canadians heading across the border for healthcare is because it costs tens of thousands of dollars. So what they're hypothetically imagining is not actually what's coming, right? It's something, we might all accept the first scenario, maybe, that I described, but not the second, and it's actually the second that's on the docket here. That's the problem, right? So it's trying to reach those people and say, it's not what you think it's going to be. It's more like dentistry, where, generally speaking, people without dental insurance just don't get their teeth taken care of. Like that's what happens.
Very good point about dental care. Okay. I think that covers it. That's the conclusion of our panel here. Thank you all for a very insightful discussion. Thank you to our audience for participating and engaging. Also, thank you to our publisher, Romy, our reporter, TechWiz, Eric, for making this such a successful event. We will have a recording of this event available for anyone who wants to see it again or share it with folks who couldn't make it today. But other than that, thank you, and I hope you have a happy rest of your summer. Stay cool out there. Thanks, everyone.
Thank you.
Thank
Bye-bye.
you.